Welcome back to the deep dive. Pharmacology can feel like a mountain to climb, especially memorizing all those drug effects. So today we're tackling a big one, cholinergic-blocking drugs.
That's right, often called anticholinergics.
Exactly. And our mission is simple. Break down this complex topic, the mechanism, the uses, and yeah, the crucial nursing safety points into something really clear and memorable.
Think of it as understanding the body's autonomic brake system.
Okay, let's set the scene. Remind us about the parasympathetic nervous system, the PNS.
Right, so the PNS is your rest and digest system, calms things down, slows the heart, gets digestion going.
Yeah.
And the main chemical messenger doing that work is acetylcholine, or ASHE.
ASHE binding to cholinergic receptors. Got it.
Yeah, that's the normal process.
So if these drugs are cholinergic blocking, they're basically stopping that. Parasympatholytics, right? Stopping the brakes.
Precisely. You inhibit the PNS, and when rest and digest is offline, what happens?
The other side takes over, the sympathetic system.
Exactly. The fight-or-flight system, the adrenergic side, gets free rein. That's the core idea.
Yeah.
Blocking the PNS often looks like stimulating the sympathetic system.
Okay, let's zoom in. How do they actually work? Like at the receptor level?
Okay, so they are what we call competitive antagonists.
Competitive antagonists, meaning?
Think of it like musical chairs. Agonist wants to seat the receptor, but the drug gets there first and just sits there. It doesn't do anything. It just blocks agonist from binding and having its effect.
Ah, okay. It occupies the space.
Right. And crucially, they mostly do this at the muscarinic receptors. These are the main PNS targets in places like smooth muscle, the heart, glands.
Not the nicotinic ones.
Not really, no.
Yeah.
Not unless you give really high doses, which gets into toxicity territory.
Yeah.
Usually it's muscarinic blockade.
That's a key distinction. Okay, so effects. Blocking the PNS everywhere means lots of potential side effects.
Oh, absolutely. Widespread effects. But there's a fantastic mnemonic to help remember the classic signs, essential for clinical practice.
Let's hear it. The one everyone learns.
That's the one. Hot as a hare, dry as a bone, blind as a bat, red as a beet, mad as a hatter.
Catchy. And practical.
Totally. Those 5 points guide your whole assessment for anticholinergic effects.
Okay, let's walk through that system by system. Cardiovascular first. Our sources mentioned something tricky about heart rate. Sometimes slowing it. That seems backwards.
It does seem backwards. At really low doses, there can be this brief initial slowing effect. It's a bit paradoxical.
But generally?
Generally, at the usual therapeutic doses, like with atropine, they block the vagus nerve's inhibitory effect on the heart. The vagus nerve normally acts like a brake on heart rate.
So you block the brake?
And the heart rate goes up, sometimes quite significantly. That's why tachycardia, palpitations are common adverse effects.
Makes sense. Respiratory system.
Here, the effects are often helpful. They decrease bronchial secretions, less mucus, and they relax the smooth muscle in the airways. So, bronchodilation opens things up.
Useful in asthma or COPD, then?
Potentially, yes.
Okay, moving to GI and digestion and urination. Blocking the rest and digest here must mean slowing things down.
Absolutely. In the GI tract, you get decreased motility, less peristalsis. Clinically, that means constipation, a very common side effect.
And the bladder? GU system?
It's kind of a double whammy. The main bladder muscle, the detrusor, relaxes so it doesn't squeeze effectively. And the internal sphincter, the exit door, tightens up.
So hard to pee.
Exactly.
Yeah.
High risk of urinary retention.
And the blind as a bat. What's happening in the eye? You mentioned cycloplegia.
Right. Cycloplegia means the lens gets paralyzed so the eye can't focus properly. Blurred vision. Plus you get mydriasis, pupil dilation. Big pupils.
Which lets in too much light.
Yep. Light sensitivity. And both effects together can increase the pressure inside the eye, which is why glaucoma, specifically angle closure glaucoma, is a major concern.
Okay. Then DRY and hot. That connects to the glands.
Directly. Decreased saliva, that's the dry mouth, and critically decreased sweating. The body can't cool itself effectively. That's the hot part.
And finally, mad as a hatter, the CNS effects.
Yeah, especially at higher doses or in vulnerable people like the elderly, you can see confusion, disorientation, delirium, even hallucinations.
Scary stuff. But you also said CNS effects can be therapeutic.
Yes, that's the other side of the coin. At lower controlled doses, they actually help decrease muscle rigidity and tremors. Think Parkinson's disease, or those side effects you sometimes see with certain antipsychotic meds, the extrapyramidal symptoms. They help rebalance neurotransmitters in those cases.
Fascinating. So, given this huge range of effects, where do we actually use these drugs most often? What are the big indications?
Well, neurologically, like we just said, Parkinson's and drug-induced movement issues.
Okay.
Cardiovascularly, atropine is a cornerstone. It's used emergently for symptomatic bradycardia when the heart rate is dangerously slow, and certain types of heart block. It literally speeds the heart up.
Life-saving.
Definitely. Then in GI, they're used for things like irritable bowel syndrome, IBS, to calm down spasms and hypermotility.
And GU must be for the opposite problem.
Exactly. For overactive bladder,
Uh,
OAB, they help control that urgency, frequency, the incontinence. Also used preoperatively sometimes
oh, boy.
to dry up secretions. Saliva, respiratory mucus,
Yeah.
makes procedures like intubation safer and easier. Glycopyrrolate is common there.
Okay, that covers uses. Now, the flip side, contraindications. When should we absolutely not use these drugs?
This flows directly from the mechanism.
Ugh.
If blocking the PNS makes a condition worse, you avoid the drug.
Top of the list.
Angle closure, glaucoma, increasing eye pressure is a no-go. Myasthenia gravis, it worsens muscle weakness. And any kind of existing blockage in the GI or GU tract.
Like BPH, benign prostatic hypoplasia.
Exactly. Or if someone already has a bowel obstruction, giving an anticholinergic could make it completely blocked. Also, acute asthma, while they cause bronchodilation, they aren't rescue inhalers and can dry secretions badly. And generally, acute cardiovascular instability, though atropine and bradycardia is the big exception.
Right. Let's talk toxicity, overdose. What's the approach? And tell us more about that antidote fesoterodine. You mentioned controversy.
Yeah, overdose management is mainly supportive care, hospitalization, monitoring the heart rhythm, vital signs. Activated charcoal might help if the ingestion was very recent, like within an hour.
And fesoterodine.
So fesoterodine is the specific antidote. It works by inhibiting the enzyme that breaks down OCRAF, so more OCRAF becomes available to compete with a blocking drug. It can reverse the delirium.
Sounds good. So what's the controversy?
The problem is, fesoterodine itself can cause serious adverse effects. We're talking seizures, and even cardiac asystole, the heart stopping, really dangerous.
Whoa.
Yeah. So because of that risk, its use is really limited, typically reserved only for severe life-threatening delirium or agitation, where the benefit of reversing the CNS effects is judged to outweigh the significant risks of the antidote itself. It's a tough call.
High stakes. And drug interactions. Must be a minefield given how widespread the effects are.
Huge potential. The main concern is additive anticholinergic effects.
Meaning stacking drugs with similar side effects.
Exactly. Lots of common drugs have some anticholinergic properties. Think older antihistamines, tricyclic antidepressants, amantadine used for Parkinson's or flu. If you add a potent anticholinergic like atropine or oxybutynin on top of those,
You multiply the risk.
you dramatically increase the risk of all those side effects. Severe dry mouth, blurred vision, constipation, urinary retention, and especially confusion or delirium, particularly in older adults. Medication reconciliation is absolutely critical.
Good point. Okay, let's meet some of the key players in this class, starting with the prototype.
That would be atropine. It's naturally derived. As we said, main uses are acute, bradycardia, asystole, also an antidote for certain types of poisoning like nerve agents or some pesticides, and sometimes pre-op to reduce secretions.
How fast does it work?
IV is immediate onset, really fast. Duration is maybe 4 to 6 hours.
Okay. Next up, the one everyone knows for travel, scopolamine.
Ah, yes, the motion sickness champion. Scopolamine is probably the most potent antimuscarinic for that specific use.
The patch, right?
Yes, the transdermal patch is ingenious. But here's the key practical point. You have to put it on behind the ear 4 to 5 hours before you travel. It needs time to get absorbed.
You can't just slap it on when you start feeling queasy.
Nope, too late then.
Yeah.
The good news is it lasts about 72 hours, but definitely warn patients. Mixing it with alcohol or other CNS depressants will significantly increase drowsiness.
Good tip. What about synthetics for specific issues, like dicyclomine?
Right, dicyclomine, brand name Bentyl. That's an antispasmodic used mainly for GI issues, specifically functional bowel disorders like IBS to calm things down.
And glycopyrrolate. You mentioned it for pre-op.
Yep, glycopyrrolate or Robinol. Its main gig is reducing saliva and respiratory secretions before surgery or procedures. Helps keep the airway clear.
Okay, and then the big category for modern use, overactive bladder, OAB. Drugs like oxybutynin, tolterodine.
Absolutely central for OAB. Oxybutynin, ditropine, and tolterodine ditrol are workhorses for managing that urinary urgency, frequency, and incontinence.
Any specific notes on those?
Well, oxybutynin is interesting because it's actually available as an over-the-counter transdermal patch, now Oxytrol. increases access, but also means patient education is key.
And tolterodine.
With tolterodine, Detrol, there's an important dosing consideration. The dose needs to be cut in half for patients with significant liver problems, or for those who are known poor metabolizers, taking certain drugs that inhibit the CYP450 enzyme system in the liver.
Why is that important?
Because otherwise, the drug levels can get too high, increasing the risk of side effects. It's a critical safety check based on liver function and potential drug interactions. And it's worth mentioning, there are newer OAB drugs too, like solifenacin, Vesicare. Often they're a bit more selective for the bladder receptors.
Meaning fewer side effects elsewhere.
Potentially, yeah. Especially less dry mouth, which can be a really bothersome side effect that makes people stop taking their medication. So sometimes better tolerated for long-term use.
Okay, great overview of the drugs. Now let's pivot to the nursing process. Applying all this knowledge clinically?
This is where it all comes together for patient safety and outcomes. Assessment is obviously key. Get that baseline history, head to toe, full medication list.
Anything specific to focus on during assessment?
Definitely focus on lifespan considerations. Infants are sensitive, but especially older adults. They're much more prone to CNS effects like confusion, delirium, agitation, plus the constipation and urinary retention. You have to be vigilant.
And for OAB patients?
You need baseline data. Document how often they're going, frequency, if they have urgency, how many times they get up at night, nocturia, any incontinence episodes. That's how you'll know if the drug is actually helping.
Makes sense. Now, implementation. Putting the plan into action. Key nursing intervention.
Fluids. Encourage patients to drink plenty of water, maybe 6 to 8 glasses a day, unless contraindicated. Helps for the dry mouth and the constipation.
Good practical advice.
Also, a safety check if you're giving injections. Always double-check compatibility if you're mixing anticholinergics like atropine or glycopyrrolate with other drugs like opioids in the same syringe. Common pre-op practice, but needs verification.
Right. And you mentioned eye drops earlier. There's a specific way to give them.
Yes, critical technique to minimize systemic absorption. After putting the drop in the eye, gently press a tissue on the inner corner of the eye, the punctum or inner canthus. Hold it there for about 30 to 60 seconds.
Why does that help?
It blocks the tear duct, preventing the medication from draining down into the nose and throat, where it can get absorbed into the bloodstream and cause systemic side effects. Simple but effective.
Okay. Managing side effects. Dry mouth.
Frequent mouth care. Oral rinses, alcohol-free ones, or best sugar-free gum or hard candy can stimulate saliva. And really important, encourage regular dental checkups because chronic dry mouth increases the risk of cavities.
And the T problem. Heat safety.
This is a huge patient teaching point, especially for the elderly. Since these drugs stop sweating, the body can't cool down properly.
So they need to avoid
Hot weather, saunas, hot tubs, strenuous exercise, especially in the heat. The risk of overheating, hyperthermia, even potentially fatal heat stroke is real. They must understand this.
Got it. What about vision changes?
Advise wearing dark glasses or sunglasses outdoors because of the light sensitivity from pupil dilation. And if they experience blurred vision or drowsiness, sedation. Absolutely no driving or operating heavy machinery until they know how the drug affects them. Safety first.
And for constipation.
Besides fluids, encourage increasing dietary fiber if appropriate for the patient.
Okay, finally, evaluation. How do we know if the therapy worked and if it's safe?
You look back at the goals. For Parkinson's, are tremors and rigidity reduced? For IBS, is there less GI pain and spasm? For OAB, are they voiding less frequently, having fewer urgency episodes? Measure against that baseline data.
And monitoring for problems.
Continuous monitoring. Watch for adverse effects.
Yeah.
Heart rate too fast, confusion, difficulty urinating, decreased sweating. And be alert for signs of actual toxicity, delirium, hallucinations, significant cardiac rhythm changes.
That covers a lot of ground. So to wrap up, we've seen how blocking these muscarinic receptors effectively lets the sympathetic nervous system step up, impacting everything from the heart to the gut to the eyes.
Yeah, the big picture is these are powerful drugs with really important uses, from treating bradycardia to OAB to motion sickness.
Yeah.
But because they touch so many systems, they demand careful nursing assessment, vigilant monitoring, and thorough patient teaching, especially, as we've stressed, in vulnerable groups like the elderly.
Absolutely. Which brings us to our final provocative thought for you, our listeners. We talk a lot about the common, maybe more manageable anticholinergic side effects.
Yep.
Dry mouth, a bit of blurred vision, maybe constipation. They're annoying but often handled. But then there are the potentially much more serious CNS effects, especially in older adults, the confusion, the agitation, the delirium. So here's the thought. When your patient reports a side effect, what's your immediate critical thinking process? Are you just addressing the symptom, like giving a stool softener for constipation? Or are you considering if that symptom, even a minor one, could be part of a bigger picture? Could it be an early sign of systemic drug accumulation reaching dangerous levels, maybe tipping towards those more serious CNS effects?
That ability to differentiate between a manageable side effect and a potential warning sign of impending toxicity, that's where sharp clinical judgment really comes in.
Exactly. Something to keep thinking about in your practice.
Well said. Thanks everyone for joining us on this deep dive. Hope it was helpful.
Keep digging into these complex topics. Keep learning. We'll talk to you next time on The Deep Dive.